Good afternoon, everyone. Thank you for joining us today for our webinar on the Severe Asthma Charter. Our topic today is a very important one regarding your choice when it comes to not having to rely on oral corticosteroids, or OCS, for your asthma treatment. We would like to take an opportunity to thank our sponsors of our webinar, as well as other programs and services that we run throughout the year. Those sponsors are GSK, AstraZeneca, and Novartis. Just a few housekeeping items before we start. This webinar recording will be available on our website, asthma.ca, on May 11th, 2020, in case you missed any part of the webinar or you want to review it in the future. Feel free to add your questions and send them over to info@asthma.ca, and we'll forward your questions to get them answered by Dr. Kaplan. Also, let us know how we did. Email info@asthma.ca and let us know what you liked about the presentation and anything we can do to make it better in the future. As well, please don't forget to share. Share this webinar with your network so that we can reach more and more people living with asthma and their caregivers throughout Canada. My name is Jonathan Kirby. I am the Manager of Programs and Services at Asthma Canada. Asthma Canada's mission focuses on education, advocacy, and research for people living with asthma and their caregivers, helping people live healthy, active, and symptom-free lives. We've been supporting Canadians with asthma for over 47 years, helping them manage their chronic disease through programs like our Asthma and Allergy Helpline. This is where we connect people living with asthma and their caregivers with certified respiratory educators to answer questions and help our community better manage their asthma. Our webinar series, like this one, we host webinars every couple of months to keep our community informed on the latest information and vital topics in asthma. This year, we are focusing on the Severe Asthma Patient Charter to better inform our community and the public of what to do when you have severe asthma. Speaking of the latest information, you can go to asthma.ca and look at all the publications we have in our publication section and inform yourself on, again, the latest and greatest in asthma research, education, and to better inform yourself in how to manage your asthma as best you can. As well, we have our Asthma Canada Member Alliance, which we encourage you to join. It is a community of people with asthma, their caregivers, healthcare professionals, and the public. We keep them up to date with monthly ACMA blasts and new and relevant information to help our community live their best lives while living with asthma. Now, this month is Asthma Awareness Month, hashtag Asthma Awareness Month, as we say around here. May 2020, we are super excited, and we just passed actually May 5th, which was World Asthma Day. Make sure you share this with as many people in your networks, your social media friends, your family. Asthma awareness is so important, and as we know, asthma affects over 3.8 million Canadians and hundreds of millions of people throughout the world. We observe World Asthma Day and Asthma Awareness Month every year to promote our mission and work towards finding a cure for asthma and to help people live symptom-free lives. Using the hashtag World Asthma Day or hashtag Asthma Awareness Month to promote asthma awareness in your network and join us in supporting people all across this country. And now to introduce our amazing speaker for this webinar, Dr. Alan Kaplan. Dr. Kaplan is a member of our Medical and Scientific Advisory Committee. This cross-discipline committee of experts from across the country helps us engage with the medical and scientific community on critical asthma-related matters so that we can better inform our community and the public about asthma. In addition, Dr. Kaplan is a family physician that works in the York region of Ontario and is part of many different associations dealing with respiratory care throughout Canada. We want to thank Dr. Kaplan so much for taking the time to join us and speak about such an important topic in our series. And without further ado, Dr. Kaplan, I'll let you go.
Thanks, Jonathan, and thanks everyone for joining. I appreciate your persistence in joining us as we had some technical problems last time. So hopefully you'll have the opportunity to have a listen to this now. I'm a family physician with an interest in respiratory medicine. I chair something called the Family Physician Airways Group of Canada, and involved a number of other respiratory initiatives. This program is sponsored by some pharmaceutical companies, as you know, but I'm not being compensated for giving this talk. So I work with all the different pharmaceutical companies that make asthma medications. Let's say there's no conflict, I think, in this particular talk today. So what I really want to talk today about is the fact that we have a topic called severe asthma, but I want to differentiate that from uncontrolled asthma. I want to talk about how we'd evaluate as a clinician and how as a patient you decide what your severity of your asthma is. I want to talk about some options, and then I want to talk about some things that we don't normally talk about when it comes to asthma, and some things we want to talk about to improve your quality of life. Now, difficult to control asthma is expensive. Dr. Mohsen Sadapasadi just did an analysis in BC and showed that while 7% of the patients in BC have 7% have severe asthma, it's responsible for 61% of the costs of asthma across the country. Asthma is not just something to deal with. It has real risk of morbidity, of missed opportunities in life, hospitalizations, and unfortunately even deaths. And we want to prevent that from happening. We want people to have a good, complete life without having any restrictions at all. And unfortunately, there are still deaths that occur in asthma. This is a young man who died in London, Ontario, this last September of his asthma. He went to the bathroom to use his blue puffer for his asthma, and he didn't come back, and they found him unfortunately demised. He told the teacher that his puffer wasn't working very well, and that's why he went out to the bathroom. So we still have issues that we want to do and make asthma outcomes better. And we can make it better. And this is a story of Finland. And Finland had quite a disastrous amount of asthma deaths and hospitalizations going back into the early 80s, as you can see. And they had a cross-country decision led by Terry Hatela to say, let's make a difference here. And they ensured that patients with asthma could get medications and they could decrease the costs. And with that, they decreased hospitalizations and deaths with asthma. So systematically, we can make these differences, and we should be able to get good control of our asthma. So that's where we are right now. I thought we should touch base with COVID because we recognize that this has been a very unusual time for all of us. And while this is the recommendations for GINA as of April 3rd, they haven't changed as of now. The recommendations are still the same based on GINA as well as the Canadian Thoracic Society. And the recommendations with respect to asthma and COVID is that keep taking your medicine. That's what's really important. The last thing you want to do is stop taking your inhaled steroids because you're concerned it's going to worsen your immunity. It does not. You do not have an increased risk of getting COVID because you're on inhaled steroids, either nasally or inhaled. And you want to keep on your medications because you don't want to flare up with your asthma, because then it's hard to know whether it's your asthma or your COVID that you're getting that from. So if you're on inhaled steroids, keep taking them. And if you're not controlled, increase your dose of controller medication. Take them regularly to get good asthma control. If you're on oral corticosteroids regularly for asthma, well, that's a group of people we're going to be talking about in this particular webinar, and that's a very severe subgroup, and there is some increased risk to be on oral steroids to your immune system. There's no question about that, but stopping oral steroids suddenly leads to adrenal suppression and will lead to other bad things happening to you. So again, do not stop anything on your own. Anything you're going to do in conjunction with your clinician. If you're on a biologic for severe asthma, again, this is not something that's going to affect your immune system adversely and increase your risk of COVID or increase your risk of having more severe outcomes with COVID. So keep taking your asthma biologic medications. It's very important to keep doing so. If you don't have an action plan, it's a good idea to have one. Contact either your provincial associations, or your healthcare clinicians, or look up an action plan online. Or speak to your educator to create one. It is easy to be done. It's easy to make a decision on what you're going to do. The simple phenomenon is if things worsen a little bit, you increase your dose of controller. Usually you quadruple your inhaled steroids and maybe add on an oral course of steroids. If you need to, then you need to do this. You need to know when you should seek help. So everyone should have an action plan, especially right now when people do not want to be coming to doctors' offices so they can act on this on their own. Something that is a change is avoiding nebulizers, and nebulizers are a pretty good way of dispensing medication, but they're a really good way of dispensing aerosols and viruses, so these should be discontinued. And the data is very clear that you can get just as good outcomes with MDIs and dry powders as you can with a nebulizer. So if you're using a nebulizer regularly, it's also going to take a lot of time in your day. Consider getting this changed over with your clinician. The only exception to this would be if you live on your own, then using a nebulizer is not going to harm anyone. As a clinician, it's a little difficult now because doing spirometry is an aerosol generating procedure, and we want to protect both the patients, the clinicians, and the healthcare workers doing the spirometry, so we recommended against doing that. Even peak flow meters, which many of you do, should be done in a well-ventilated area, perhaps like on a balcony or something like that, to make sure that you're not spreading the potential virus particles within a room. Make sure that the areas are wiped down afterwards. Of course, we have recommendations across the country and the province where you live about hygiene strategies, social isolation, social distancing, and so on. and we want to make sure to keep all those rules overall. So take care of anything with aerosol generating properties. You want to be very careful if you're dealing with people on oxygen and needing suction and so on. And of course, people who are caring for people with the illness are a particular risk, so make sure you use the appropriate precautions. So moving on to asthma, and especially severe asthma, when we talk about the prevalence of severe asthma, and you look at this plot diagram from the Dutch population, it's very similar numbers to what we have here in Canada. If you look at the number of people with asthma altogether that need to be on step 4 or 5 treatment, the highest level of treatment, it's less than 1 in 4. Of that group, only about 3/4 of them continue with that step 4 or 5 treatment, but still have issues with control and exacerbation. So they would be considered difficult to treat asthma. And only about less than 5% of those, I said in Canada about 7%, but less than 5% are going to have everything done properly, good adherence, good technique, dealing with comorbidities, on step 4 to 5 therapy, and still uncontrolled. And those are the group that we talk about severe asthma, and those are the group that we would talk about considering next level therapies, which we're going to talk about here. So uncontrolled asthma is having symptoms not well controlled, frequent exacerbations. What's the right number? Is it 2 or more per year? Any course of prednisone, in my mind, is a failure of the system. It means that either we've not given you enough maintenance therapy as a clinician, or you've got an action plan, or you've not acted on your action plan, or you as a patient have not been adherent to medication, or there's been some kind of trigger that we can't foretell, like influenza or potentially COVID, that could cause an exacerbation. Serious exacerbations, a history of such means you've got to be very careful. And if you've done everything right and you're taking medications, you still have airflow limitation, you have chronic airflow scarring, then again, that's not going to be control of your asthma. And I'll contrast that to severe asthma, which is you're on high dose OCS plus a second controller, or and you're still uncontrolled, or you've been on systemic corticosteroids and intermittently uncontrolled. That would be considered to have severe asthma. Now, severe asthma is not just something we're describing. While it's not common, I've already explained to you how it's caused a lot of effect on quality of life. It increases your risk of hospitalization, increases your risk of needing prednisone and being on prednisone, and of course mortality and the effects of prednisone. And of course, it's going to cause some pretty significant cost to the system. In addition, someone who's living with severe asthma with recurring exacerbations, may certainly have some psychological manifestations of this. It's probably pretty scary to have situations where you can't breathe, and it may cause some anxiety and depression. And that fear is something we want to work towards. And what I want to reassure you is that we can actually help, and there's things we can do to make your breathing better if you're severe asthmatic. And the sky's the limit now of the choices of therapy we have, and people should not have to live with those fears anymore. So the group of you who are listening or clinicians, who should you be concerned about? Well, if you're getting frequent exacerbations of your asthma, frequent episodes of prednisone, frequent hospitalizations, frequent emergency visits, frequent effects of your life that you cannot live your life normally, then you should be concerned. If your asthma is not controlled, if you need oral steroids, and I think even one, every time you need a course of oral steroids, there should be a very significant evaluation done by both you and your clinician saying why. Why did this happen? Is there something I could have done to prevent this? Have I been adherent to my medicine? Have I been taking it properly? Is there a trigger I can get rid of? Is there something I can do to make sure this never happens again? And that's how we have to approach this. And if it requires stepping up therapy to do that, then so be it. Now, this is some work done from a study in 2018 that looked at the risk of exacerbations. And exacerbations, again, are very disrupting. And if you go across the cohort of severity, from the blue to the light blue, from BTS1 to BTS6, which is British Thoracic Society levels of severity. We don't describe it quite the same way here, but you get the idea. As you have more severe disease, you have increased likelihood of having exacerbations. Well, you can see that as you get older, your risk of exacerbations also go up. So age is a factor here as well. Older asthmatics tend to have more exacerbations than younger asthmatics, and of course, more severe asthmatics have more exacerbations than less severe asthmatics. But even people with hetero-defined mild asthma can still have exacerbations needing prednisone. So nobody is immune from this, and we have to be very clear about what we can do to try to prevent this from happening. If it's mild disease, the reality is it's often due to non-adherence and taking medication only when you sort of feel like you need it. More severe disease requires other steps to get people under control and preventing those exacerbations. Now, the premise of this particular talk is that oral steroids are a problem, and we want to do everything we can to avoid the use of oral steroids. Now, if you need them, take them. There's many conditions that require the use of oral steroids, but we're always looking for alternatives, no matter what the condition. In asthma, we now have many options, and we'll talk about that. And the reason oral steroids are a concern is because the body was not meant to have exogenous steroids being used all the time, and it has side effects. It has side effects on the skin. It has side effects on the sugar and causing diabetes. It causes fluid retention and weight gain. It causes hypertension. It can cause direct peptic ulcers. It can cause osteoporosis and fractures and something called aseptic necrosis of the hip, where the bone in the hip dies and you actually have to have a hip replacement. It can cause muscle weakness and steroid myopathy. It can affect your immune system and cause increased risk of pneumonia. And there probably is a little bit of a risk for people who are on long-term steroids in terms of catching COVID a little more easily and having a more significant episode. And there is actually a risk of actually becoming, frankly, psychotic if you're using steroids, and some people have had that side effect. That's quite the list of things you'd like to avoid, and therefore, if we can avoid oral steroids, that's going to be a good thing. This is a study from the US that looked at people within 1 month after having an oral steroid burst. And you can see that the numbers here, that in the 1 month after having a course of oral steroids, their risk of having sepsis was 5 times, a DVT and a clot 3 times, and a fracture almost 2 times. So steroids are not benign. And again, not telling you, those of you that are taking it, to stop taking it tomorrow. But what I am telling you is get back to your clinician and say, why am I on this stuff? What else can I do to try to get off this stuff? Now, if someone has significant asthma, we go through a number of steps to try to define what's going on. So you've got uncontrolled symptoms, you're not feeling well, you're coughing and wheezing and short of breath, and maybe you're just on prednisone. The first step, of course, is do you have asthma? Have you actually had a spirometry, or have you had a methacholine, or any other testing that we can do to define whether or not it actually is asthma? Sean Aaron, a respirologist in Ottawa, led a study that showed that a bunch of people who were diagnosed with asthma in the population with a telephone digit dialing, actually a good number of them didn't actually have asthma. And the number one reason why they were found not to have asthma, or the diagnosis was mismade, is no one ever actually did spirometry on them. So make sure the diagnosis is right. The next step after that is make sure that we are trying to do as much as we can for our environment. Ironically, COVID has helped our environment. It's decreased the amount of travel and therefore increased air quality. Our air quality is as good now as it's been for a long time. We actually can improve the planet. Make sure that the person's medications are being used regularly as per instructions, and that they're being used properly. And inhaler technique is a very big issue. These medications are not intuitive, and they require reassessment to assure that they're being used properly. The good news is there's YouTube videos that can describe exactly how to use every single inhaler out there. If you're not sure, have a look at those. And if you're still not sure, speak to your pharmacist or your clinician. Now, many things can look like asthma, and many things can make the asthma a little bit worse. I'm not going to go through that entire list now, but there's quite a list of things that can do that, and we're going to talk a little bit more about those things. Some of the things that make asthma worse include having rhinitis or having congestion in the nose, as well as causing GERD or acid reflux that can actually burn the lungs. So these things have to all be considered as you step through things, and they have to be treated accordingly. Now, if you're still on high-intensity treatment and only poorly controlled or partly controlled, and you're doing everything else right, you're taking your medicine, taking it properly, you've gotten rid of the triggers, you stopped smoking, you potentially have gotten rid of the pets if you're allergic to them, or at least put them in another room and have someone else brush them, and so on. You've done what you can, and you're left with symptoms. You've got severe asthma. At that point, as clinicians, we have to decide what type of severe asthma there is, and there's more than one type, and the different types respond to different treatments accordingly. But each one of those types actually has a treatment. So as I'm saying before, be hopeful, because there's many things we can do to make you feel better as an asthma patient. And for the clinicians who are listening to this, there's things you can do in your practice to get them to the right person to help them with their asthma control. Now, again, as I go back into basics, the basic evaluation that you should do as a primary care health practitioner before making a referral is going back to the basics. And as a patient, you want to make sure that these things are being done properly if you're having any trouble with your asthma. Has your asthma been diagnosed? Have you ever actually had a lung function test? Have you ever had spirometry? And sometimes, of course, spirometry may be normal. When you're feeling better, you may need a challenge test and so on. Are you taking your medication regularly the way you're supposed to? Are you taking it properly? Have you done something about the triggers? And I've mentioned that quickly. The obvious one is smoking cessation. Secondhand smoke is a real issue. If you're allergic to pets, that's a real problem when they live in your house. Try to keep them out of your room. If you have a cat, then have someone else in the house brush the cat, and that works too, and wash the cat. That works 2 ways. It decreases the amount of their their allergen, number one, and number two, the cats hate being washed, so they run away. My tongue is in my cheek. At least try to keep the animal out of the room and decrease the amount of salivary contact. And the comorbidities I've already discussed with you, which include rhinitis, stuffy nose, and acid reflux, as well as things like sleep apnea. And being overweight also tends to decrease asthma control. That's something we can work on. So these are some of the mimickers. I've said it's quite a long list here. Some of these are infectious, some of these are inflammatory conditions, some of these are rheumatologic conditions that have some lung manifestations. Vocal cord disorders are interestingly because the upper airway can also cause wheezing, and you can get things like stridor for something called vocal cord dysfunction, which is a paradoxical movement of the vocal cords, which requires someone to actually look at your vocal cords when you're breathing to make a diagnosis. There could be concomitant chronic obstructive lung disease if there's the history of smoking or alpha-1 antitrypsin deficiency. You could have been diagnosed with asthma with cough and sputum, and in fact actually have bronchiectasis or pus in your lungs, which can manifest it as well. So if you're a patient with respiratory symptoms, you've been diagnosed with asthma, yet you're not getting better with the initial treatments, the first question would be make the diagnosis and rule out other things. Now, the tests involved, we've alluded to, include first of all spirometry, which is forced expiration into a machine, and you measure before and after giving a bronchodilator to see if there's any obstruction that reverses. Because spirometry because asthma is a variable disease, and sometimes it's not too bad. Sometimes you need a challenge test to give something to irritate the lungs to see how much it drops the lung function. Pheno is an office-based procedure now that's not available in very many places because it's not funded by the government. If anyone's listening here who works in the government, please consider funding Pheno down the road. It's a very simple office test which you blow into a machine. It gives you a measurement of exhaled nitric oxide, which is a surrogate measurement for eosinophilia, which is the inflammation in asthma. If you're lucky enough to be in a center in a country, there's about 5 of them that actually can measure sputum eosinophils, then that's actually a really powerful way of measuring the actual inflammation in the lungs. And it's probably the most accurate way of looking at the inflammation that goes on in an asthmatic, but it's not available across the country. Blood eosinophils in the CBC, everybody gets a blood count done once in a while, and that's actually very nice, not so much to drive therapy, but to predict those people who are going to need more therapy. And people who have a high blood eosinophil count tend to have more exacerbations and tend to respond to medications better in asthma as well as in COPD. Serum IgE is a test we do when we're looking for people who have elevated immunoglobulin E, which is an allergen-mediated immunoglobulin, and is one of the markers for different biologics, and also tells us what you're allergic to. And then, of course, allergy testing, whether you do it by a pinprick or you can do it by blood tests that can do that as well. So lots of tests that may be done for you as an asthma patient. If you've got bad disease and you haven't had none of these things done, then you have an issue and you need to talk to your clinician about it. Now, those comorbidities we talked about, rhinosinusitis, it's nasal congestion. And of course, if you don't treat allergic rhinitis well, you can't get the asthma under control and vice versa. Sometimes if people have a concern about sinuses and polyps, you may get a CT scan. GERD is sometimes easy to know because you have acid when you bend over. You have sour, brash taste in your mouth when you bend over. It can change your voice and things like that. But sometimes it can be silent, and you have to actually do something like a manometry, which is a bit more of an invasive test, but can be done. Talked about vocal cord dysfunction already. Talked about some of those other inflammatory conditions that can happen. Work-related asthma is probably worth discussing. If you tend to get better on the weekend and worse at work, and you're working in a situation where you might be exposed to something that can cause asthma, there's many different things that can sensitize your lungs in the work opportunity. And if that is happening, suggest this to your physician and have a conversation about it and get a referral to the right person, because that's quite a complicated testing steps we do for work-related asthma that includes peak flows at home and at work and methacholine at home and at work to try to define then particularly what you may have a reaction to. But if your asthma is getting worse and you have adult onset asthma only, that you didn't have it as a child, let's think about your occupation, because that might be an issue. And of course, everything that happens in our lives is mediated by the brain. So if you're anxious and depressed and having trouble dealing with your life in many ways, or just dealing with your asthma, that's going to affect your outcomes and needs to be talked about. So these are the comorbidities we talked about. Of course, the inflammatory conditions in terms of eczema can also be rhinitis in the skin. We've talked about other conditions in the lung, and I've listed these things already. So overall, we want to go through these things. You want to assess the adherence, the inhalation technique, and the environment, and go through all of these things. So let's summarize them one at a time. How do you decide that you're adherent? Well, everybody forgets to take their medication once in a while. And are you doing this on purpose? Are you doing it accidentally? If you're doing it accidentally, then you need to make reminders for yourself to not forget your medication. If it's once a day, you do it when you get up in the morning, perhaps after you eat and before you brush your teeth. It's twice a day, the same thing. You do it at nighttime before you brush your teeth. If you're not brushing your teeth, you got a different problem. We have to make sure these are being done. Now, some people do this intentionally. They decide, no, I don't need to take my medication, or I'm afraid of my medication. I have fears of it. And that's a fair thing to have happen. If you're really afraid of your medications, you're not convinced you need it, you're worried about the side effects, then don't just not take it, because as a clinician, we may not realize that. Explain to us why you're worried and upset and what it is your concerns are, and we can actually go through those concerns with you and answer your concerns, or come up with an alternative therapy potential for you. Don't just stop taking medications because you're concerned about them. Talk about it. As a clinician, how do we know? We ask the question, but we all know that we don't always get the exact correct answers. We could do drug dispensing records from the pharmacy, which can be sometimes of value, but doesn't mean they're taking it. It just means we're seeing it. We can talk to family members as well about that. Of course, sorry, I will go backwards a little bit. Inhaler technique is important here. And of course, if you ask the patient to show you their inhaler technique in front of you and they have trouble taking the inhaler out of the box, you got a pretty good idea they haven't been adherent to it in the first place. Then make sure that they show you how they use their inhaler. It's really important not to just describe it, but to watch them. Okay, so it's called a teach-back method. As a clinician, you show the person how to use it, then you get them to tell you how they're going to use it, and then they show you how they're going to use it. And it's important to keep doing this over time, because unfortunately people forget how to do it, even people who are well trained. As a clinician, if you're not quite sure how to use some of the new inhalers, and there's lots of new ones, again, have a look on a YouTube video about it. And again, what someone may have an occupational or an environmental exposure to, consider what they may need a skin testing or a blood test to look at the different allergens they may have, and we've already talked about occupational asthma. So adherence, big issues here in terms of perceived need versus concern. How much do I need to take a medication versus my concern about the side effects? And isn't everything in life about this? How much do I need to get where I'm going versus how much concern do I have about going through that yellow light? And this is what our lives are all about. So we make these decisions based on the context of our past experiences, our cultural influences, what our parents tell us and our friends do us, and how satisfied we are about being able to make those decisions. Now, we did this abstract of a questionnaire to look at the necessity of SABAs and the over-reliance of SABAs. And unfortunately, there's many patients out there, that many of you perhaps listening, who tend to use an awful lot of SABA. And I understand why you use SABA, because it's the drug, the Ventolin or Tribulene or Bricanol. It's the medicine that you've been using all these years to make yourself feel better when you don't feel well. It's been a crutch, and I understand why that's something you'd not want to lose. However, if we do asthma right, you hopefully don't have to be grabbing medications for symptoms. And if people are just using their SABA and not using their controller, they're not treating the inflammation in the lung, and therefore they're at risk of having exacerbations. So we created a questionnaire to decide on how people look at this. I'm afraid to say adherence is a real problem, and this gives you an idea here of across Europe study done by Klaus Rabe that looked at how often do they use their blue one versus their red, orange, purple ones. And you can see that the blue one gets used regularly, but their controllers are not being used regularly. Even people on the far left with severe persistent asthma still only use their controllers 30% of the time. So when I see someone who's not controlled, the number one reason they're not controlled is because they're not taking their medication. Number two is because they're not taking it correctly. And number three is because the diagnosis is wrong. How much SABA is too much? Something called the Asthma Right Care Initiative, which is a global group that we put together to try to have a look at why people are overusing SABAs and not taking proper anti-inflammatories. It's because we don't get quite an idea of how much SABA that really is. So each inhaler has 200 puffs per inhaler. And if you're familiar with our guidelines, it says we shouldn't be using our reliever more than 3 times a week. And even that's probably more than GINA says, which is our global guidelines, which say twice a week. Well, if you use it twice a week, right, at 2 puffs, that's 100 puffs a year, right? Sorry, 200 puffs a year, 4 puffs a week. So you can see that if you're using 3 puffs, you're going to be using 3 puffers. You're using puffs every day. And really that tells us we're using an awful lot of inhalers. So this just sort of gives an idea of how many puffs you're using a day and how many puffers per year you're using. and how many days you're actually using the medication. Hopefully it's something to sort of make you allow those numbers to make sense. I understand that SABA is something that people get very attached to. And these are some pictures of real tattoos of people, and it shows the relationship with their inhaler. It says, ain't easy being wheezy, death to the wheeze, how do I love thee for their blue puffer. I mean, this is a real thing, a real attachment people have to that SABA, and I certainly understand it. What happened was you got short of breath, you were wheezing, you were uncomfortable, you went to see the doctor, they gave you this puffer, and you felt better, and it's magical. And you've needed it again, and it's there, and it's your crutch, and you don't want to be without it. But we all understand that this medication is a treatment for the symptom, not the underlying problem. The underlying problem is inflammation. And you've seen pictures like this, I'm sure, before. On the left, it's the normal asthmatic with a big wide open lumen, not much inflammation. The muscles are not thickened. The goblet cells are not big. And someone with very bad asthma, you can see this is a fatal asthma case. It's a cross section on the right. The basement membrane gets thickened. The goblet cells get big. The smooth muscle, which is the reddish striated muscle there, gets much thickened and hypertrophied. And all those cells in the submucosa are eosinophils causing inflammation. What we're learning now is that there's all kinds of pathways that cause that inflammation. That's the one on the right. And this is stuff that we've learned about more over the last 15 years than we have for all the years before then. And we know that there's different cytokines that get released by different parts of the lung, be it the lining of the lung, or be it related to a relationship between the eosinophils and the inflammatory cells, and damage to the lung tissues and the epithelium, and even effects on the smooth muscle. And different of these cytokines get released and then cause more stimulation of things like the eosinophils and the bone marrow, or it causes a release of more antibodies, that IgE we talked about earlier. So a whole different cascade there of allergic and non-allergic eosinophilic airway inflammation. And of course, there's actually some that's non-eosinophilic inflammation as well to make it complicated. So it's certainly not a one-size-fits-all. This inflammation can be the same in some people and different in others. This is the SABA questionnaire we talked about. And if you have a look at this questionnaire and you're answering those questions very high, you might want to think about how you feel about your blue inhaler. So if you think that the reliever inhaler is the best way to keep on top of your asthma, that you don't worry about your asthma because you have your blue puffer around, that the blue one's the only one you rely on, and the blue one definitely outweighs any risks of not using the blue one, and I'd rather use my blue one than my preventer, and those questions are there, then significantly you have to think about your views on your asthma and your attachment to your blue inhaler. So the new guidelines are the GINA guidelines, which GINA recommendations. They're released in 2019, just updated this year in 2020. And this was probably one of the biggest paradigm shifts we've had in asthma management in many, many years. And the big thing there is the box on the bottom that's in red. There is no more indication for using SABA monotherapy. It used to be that step 1 therapy, which is very intermittent symptoms, the recommendation was using SABA PRN, which is less than 2 symptoms a month. You just use a SABA. Well, now we recognize that asthma, even very mild asthma, very infrequent symptoms, if you really have asthma, is inflammatory and therefore should be treated with an anti-inflammatory. And as such, the recommendation for even step 1, which is intermittent symptoms, is to use an ICS formoterol, a combination of a reliever, which is formoterol, which is a long-acting beta agonist, and an ICS. And then as you step up further, the different steps, you add increasing doses of the controller, be it ICS, inhaled steroid, or ICS LABA, and steroid with a LABA, but continue to use a reliever that hopefully has some anti-inflammatory in it, so you're treating the inflammation at the time you're actually treating the symptoms. It steps up all the way to the far right, where you're going to be adding on other things like tiotropium or biologics, and we'll talk about that. And technique. Well, I mean, technique is a real issue. We have had technical issues for many, many years, and unfortunately, if you look at a graph like this, you can see that the number of people doing inhalers properly hasn't changed for 60 years. And that's kind of pretty scary to me, is that we really still have this as one of the major issues, despite the availability for technology. Here's the first inhaler, and you can see we progressed a little bit. Most things got invented in a bar, and that's what happened here. They put a straw onto a beer stein and blew some stuff into the beer stein and inhaled it. That was the first one. The second one was called a Newton chamber, where you put your head into a box, and subsequently we've gotten better and better with inhalers. As you're familiar with as well, we also have metered dose inhalers that you can put a chamber on to improve the delivery of the medication and the timing. Here's an example of a delivery system that we did with my cat. This is called an aero cat, but they have air chambers for people as well. Yes, I had a cat with asthma. That's really true. It's another story for another day. But you can see that you can actually get delivery system very well. And with the chamber, you spray into the chamber, and you allow the child, or in this case the cat, to take 6 or 8 breaths and gets the medication down to the lungs very effectively. MDIs are difficult to use and have to be inhaled very slowly. Dry powders have to be inhaled very quickly. Timing is important for the MDIs, and a chamber is probably preferable if you're going to use an MDI with a steroid. Chambers still are not perfect, and you're going to have problems even with chambers. I always thank Dr. Helen Ramsdale for this picture. And you can see what happened here. The puffer goes in with the cap on, and you spray it on with the puffer. It doesn't work. You pull it out, leave the puffer in the chamber, and this isn't going to work very well. This is an example of a patient came into her office with that. Well, here's the best asthma delivery device I've ever seen, and this goes back quite a number of years ago in the 1800s. It's called asthma cigarettes. This is a real thing. I did not make this up. You can see it effectively treats asthma and hay fever and bad breath, but it wasn't recommended for children under 8, which you can see on the bottom. So my tongue is in my cheek significantly here. This doesn't make sense. It's a bad thing for you. Anything inhaled in your lungs is bad for your asthma. Even electronic cigarettes. Don't put anything in your lungs you shouldn't. But clearly, delivery devices are important. So in terms of triggers, there's many different things that trigger. Here's a list of the top triggers that are there. Obviously, infections are big. Dust and dust mites are important. Tobacco is a huge issue. Pollens at this time of year is a big deal. Pets is a big deal. Outdoor pollution, as we can say, is actually as good now as it's been for a long time. Each one of these things have to be appreciated. So for viral infections, we want to make sure we wash our hands. And of course, no better time to talk about that right now with COVID. You also want to get influenza shots when you can, and pneumonia shots for everyone asthmatics on regular steroids. Dust you clean, but dust mites are little insects that eat your dead skin, and you can be allergic to and inhale them from your bedding and your pillows. So make sure you use dust mite covers and use the right decreased humidity. And then you go on and on. Pollens, you want to try to make sure to keep your windows closed in the allergy season and so on. Obviously keep your humidity down for mold and mildew. So, pets should be dealt with as best you can. I mean, I'm a pet lover, so I'm not going to tell you get rid of your pets, but try to minimize the exposure. This would be an example of the worst combination, the smoking cat. I thank Ken Chapman for this picture. So what else is new about asthma now? And what's coming, what's well known is that allergy immunotherapy has been shown to improve people with allergic rhinitis and asthma whose asthma is not too severe. And the idea here is that you give the body small amounts of something you're allergic to change your body's response from an IgE to an IgG, and therefore you no longer have the allergic cascade. So here's some evidence from a study from Germany where they looked at some real-life evidence of subcutaneous allergy immunotherapy on allergic rhinitis and asthma, and you can see that if the people who had allergic immunotherapy injections had much less asthma medications, and actually has the potential to decrease the prevention of asthma if it's just given for allergic rhinitis early on. So if you have allergies, especially seasonal allergies, but even for things like house dust mites and pets, you want to look at having a conversation with your doctor about an allergy evaluation to decide whether or not allergy immunotherapy is going to be useful. Unfortunately, if you've got very severe asthma and you're very brittle, immunotherapy is a little bit dangerous because it can tip you into trouble. Okay, so we've gone through all that stuff, and you say, okay, it's time to think, do I need to be seeing a specialist? I may be seeing a family doctor or a local respiratory person, but do I need more? Is there something else should be done? So if I'm still needing prednisone, if I'm still uncontrolled, and I've done all those steps, then it's important to see someone who has the expertise to consider whether or not a biologic or another treatment should be there. So a referral should be made, and this is for my clinicians in the audience. What should you include in that referral letter to make it clear, why you're referring, how was the diagnosis initially made, with maybe a copy of lung function if you can. Have you measured control with an ACT or a 30-second test? And what you've already done a good approach. You've checked inhaler technique and adherence. The person understands which one is their control and which one is a reliever. And I know it sounds silly, but some people get them mixed up. Is it affecting their quality of life? Do they have any other atopy? Do they have any other comorbidities or other factors that might affect their asthma management? And that's a very complete asthma referral to assist them in terms of the clinician who you're referring to make the decisions on the next step. Now, from there, you either, as a primary care clinician, will order these, or the secondary clinician or tertiary clinician will order these testing to help decide on the next step for biologics. Anti-IgE therapy, or omalizumab or Xolair, is done for the people who have allergic asthma, and it's based on having an elevated IgE count. Anti-IgE therapies, anti-IL-5 therapies work on the eosinophil, and the eosinophil is that central inflammatory cell, and there's a few different companies you can see that make those. And I'll talk a little bit more in detail about each one. Dupilumab is one of the new kids on the market, and it's actually predicted best by FeNO, which is that test we mentioned earlier where you exhale into a machine. It sort of predicts things a bit better, and it also has some response with the eosinophils. Periostin was another biomarker that we don't use anymore. It was for a product called IL-13, which actually failed in market, so we don't actually measure that one. So the test you might be doing is allergy testing, serum IgE, and then a CBC with the eosinophil count. Sputum eosinophils, I did mention, is not a requirement for any of these medications. However, it is the magical decision treatment because you can actually manage your asthma just based on sputum eosinophils, as done by this study, and it showed that if you used sputum eosinophils to guide your steroid therapy, you actually had much less admissions and a lower dose of steroids altogether. But it's a difficult test. You have to inhale hypertonic saline, cough up a piece of your lung, it feels like, onto a slide, and someone has to read that. It's expensive, and again, is only being done more as a research thing in Canada. This is some work done by a colleague of mine named David Price, who looked at database analyses and looked at the frequency of exacerbations and overall control in people and their blood eosinophil counts. I mentioned earlier that the blood eosinophil count is a good marker for control and the risk of future events. And you can see the higher the blood eosinophil count, the more likely things are to be in trouble. So the number certainly starts at about 300, and that's in your CBC at the bottom of the CBC. This is your blood count for the clinicians. There's going to be a place at the bottom that says eosinophils. It'll say 0.3. That means 300 cells per microliter, and that would indicate that treatment should be considered and perhaps increased. So the higher the blood eosinophil count, the less likely to get good asthma control. Now, severe asthma, especially T2 asthma, the allergic eosinophil-related asthma, is complicated. Then there's non-T2 asthma, which is not eosinophilic related. There's some different phenotypes that are there. Some of them are smooth muscle related. Some of them are related to weight, and then there's different mediators that can have this. So this is pretty complicated and may require someone with some extra expertise to actually have a look at all these conditions, try to figure out which one the person is. Do they have associated nasal polyps as a case, which makes things a little bit different? Is it early onset or late onset? All these things can make a difference to the asthma. And when we go back to the GINA guidelines, I mean, as we move up the steps from step 1 all the way to step 5, we get into step 5 there, and you can see that they're already on high-dose ICS-LABA. We can add on something else like tiotropium, which is a long-acting muscarinic antagonist. The other name for that is Spiriva, and that improves control and decreases exacerbations. You see they're adding low-dose oral steroids, but I think we want to try to prevent the use of that as best we can. So here's when we start thinking about other therapies, and there are some other treatments that are included in this. These can include something called bronchial thermoplasty for people who have very twitchy muscles. That's done only in a few centers across the country and is not a common thing being done. There's people who have neutrophilic asthma, which is a different kind of asthma, which use long-term antibiotics. But we're going to talk more here about the classic eosinophilic allergic asthma, where we consider anti-IL-5s, anti-IgE, or anti-IL-4/13s. Our Canadian guidelines also have the same methods as you can see here. This is an article in 2017. Mark Fitzgerald was the first author. And you can see as we step up, you make the diagnosis, you take care of all the details like environmental control, education, action plan, step-up therapy with your reliever, and then your preventer, assess your phenotype. And again, if it's a high IgE level, consider omalizumab. If it's high blood eosinophil count, consider anti-IL-5. This was done before IL-4/13 was released. And you consider macrolides. We talked about antibiotics for people with neutrophilic asthma. Of course, you can use chronic prednisone, but that's something you really want to try to avoid as best possible. Now, this type 2 response, this allergic response, is mediated by triggers that lead to release of cytokines from different inflammatory cells in the body. And that inflammation can either precipitate B cells, which are inflammatory cells that make antibodies like IgE, or can directly act on the mucus in the smooth muscles and the airways, or can cause increased eosinophils, which then work also to cause scarring and airway obstruction and inflammation. So anti-IgE works on the IgE situation. That's omalizumab, and in terms of the anti-eosinophilic kind, it's going to work on the eosinophils directly, which works, as you can see, on the different parts of the lung, or the smooth muscle, or actually the airway lumen itself, whether it's IL-4/13 or IL-5. And there's different advantages and pros and cons of each of these. I'll touch base shortly on those, because that's not really where I want to go too much with this talk. You're going to have to speak to a clinician to help you decide which is the best drug for you. I'll talk a little bit about the differences, so we'll have an idea of what you're talking about, but really you're going to have to decide this medication individually on a patient-to-patient with your clinician. Now, some people are going to be eligible for anti-IgE, some people are going to be eligible for we call the anti-eosinophilic therapies, and some are not going to be eligible for any biologic, and some are going to be eligible for both. And you're going to make these decisions based on your exacerbation history, your allergic history, your IgE level, your blood eosinophil count level, and of course whether or not you're on oral steroids. And all these things come into a combination together to help us decide which biologic would be best for you. Now, we talked about adding a LAMA, adding tiotropium. Really good trials here with people with step 4 disease who are uncontrolled with ICS-LABA, or actually even just on top of ICS, and it shows a decreased exacerbation risk and improves lung function. There's a new triple therapy coming for asthma, which I'll show you the study for that on. But here's the data with tiotropium that adding onto either ICS alone or ICS-LABA improves lung function and increases time to the first asthma worsening. Now, the interesting thing about tiotropium, and why I think we should be considering that in primary care, adding on to ICS-LABA, is it doesn't really make a difference whether or not these are people with high or low IgE levels or high or low blood eosinophil count levels. The effect is the same. So tiotropium effect on anybody who's not controlled with high ICS-LABA is independent of the phenotype decisions. And this is an example of the QVM, which is the triple therapy being made by Novartis. There's a triple therapy currently out by GSK as well, which is indicated for COPD. All these things are being tested for asthma. So omalizumab is the anti-IgE. It's indicated for people over the age of 6 with a positive skin test. You have to have allergy testing or some kind of blood testing showing positive testing, and an IgE level between 30 and 700. And of course, they have to already be on adequate trial of treatment on adequate dose of ICS to be considered for omalizumab. Omalizumab is unique in that it's covered by some of the provinces. It is on Ontario in these proper indications. So even if you're covered by government assistance, it's covered. The problem with all the biologics, they cost about $20,000 to $25,000 a year. IL-5 therapies, they're a little different for the different treatments. You can see all of them are related to having significant exacerbations. Eosinophil counts are important for different cutoffs for the different medications, which makes it a little more confusing. And it's not that they probably work any different, it's just that's how the studies were done. The indications, again, high dose ICS plus an equivalent, plus a second agent is usually the indication. Reslizumab did a study with more moderate disease, so you can actually go a little bit lower. Reslizumab, however, is an intravenous formulation, so there's pros and cons of each one of these things. So how they're given is, for the most part, subcutaneously, except reslizumab, which is intravenously and it's weight-based. Some people say that's the best one for that one because it's more accurate to the person because it's weight-based. Other people say the subcutaneous doses are adequate. There's slightly difference between mepolizumab and benralizumab. One works on the receptor, one works on the cell wall, and therefore they're a little bit different. Dupilumab, as I said, is also subcutaneous injection. It also has indication for atopic dermatitis. The doses are different, so the frequency are a little bit differently. Dupilumab is every 2 weeks. Reslizumab and mepolizumab are every 4 weeks. Benralizumab is every 4 weeks for the first 3 doses, and then it's every 8 weeks after that. And omalizumab is every 2 to 4 weeks, depending on the dose. In addition, some of the companies now have created at-home therapies. You can see the ones there that do have therapies. You can actually give yourself self-injections at home, and that's a progression. You have to be taught how to do it. You have to make sure that you have your first dose monitored by someone so there's no reaction, but it's all going to make things easier. And hopefully that's something that's going to make people be a little bit easier, more adherent to taking their biologics. One of the things that happens with biologics, and some people are these super responders that do fantastic with it, and they're tempted to stop taking their inhalers. Make sure you stay on a little bit of inhaler and to have that discussion with your specialist. So all the biologics work if you pick the right person for them. They improve exacerbations of quality of life. They usually allow reduction, if not cessation, of the oral steroids. And again, those super responders that I see it's a magical thing. They feel they no longer have asthma with these medications. They are so good. And it's quite a magical feeling for people who've been fighting with asthma symptoms, allergy symptoms for many, many years. and whether you treat the atopic dermatitis or the eczema as well, or the allergic rhinitis as well, all those things get better as you treat all these things. So again, if you're not on a biologic and you have the indication, have a discussion with your clinician about this, because these are quite magical drugs. I'm not going to get into all the studies of steroid reduction, but that was the title of this. Oral steroids are bad, and can we reduce them or stop them? And you can see that significant numbers, not everybody, but significant numbers can reduce the dose, reduce at all, down to almost 100% reduction in a significant number, and to a level less than 5 milligrams a day, which is considered to be more or less what your body makes on an ordinary basis, in over 50%. So it does work. Now, what's important, you can see in the placebo groups, there was some reduction in oral steroids as well, which tells us that in these studies, there are people that perhaps were not taking their medicine properly, not taking it regularly, but in the study they did, and suddenly they could come back off their oral steroids. So again, these medications are to be done on top of proper therapy, taking your medication regularly and properly and dealing with comorbidities, because you may not need these expensive medications if you do everything else right. And certainly a number of the referrals that I get are not needing biologics, because if they do everything else right, they get better. Just a little bit of data, just so I'm giving everybody a little bit of time here. Dupilumab shows, again, reduction of oral steroids significantly. The higher the FeNO, the more the efficacy of this particular drug. And you can see, again, reduction in exacerbations with dupilumab. And this is not maybe a little bit, not terribly dissimilar from all the IL-5s and IgEs. They all reduce exacerbations significantly. So the right drug for the right person is very important. Now, the question you may have is, what about safety? First, I'll mention costs. As I said, these are expensive, and they're not all covered, and there's ways that your clinician can look into coverage for you with your drug plan and with the government, so don't be afraid of asking. Safety, there's a lot of side effects here that are listed, which you can read. These are side effects that happen in large drug trials, and most of them are things that just reported in any trial, and are also reported in the placebo groups. So headache, back pain, catching a cold with pharyngitis, you can see upper respiratory tract infection, getting influenza. Well, that's just, you put enough people in a study, you're going to have these symptoms. People have a side effect of asthma is always an interesting one in an asthma study. Of course, having injection site reactions is real. Some people get reactions to this. I've seen people who've had funny side effects from it, hair loss and muscle aches and stuff, and weird things are going to happen. And again, on an individual basis, if something is bothering you with your medication, you need to understand that's happening. If you're having something weird response to a medication that's new and it's happening to you, then speak to your physician about it. You may have to consider a trial of something else or stopping it or something like that. Hypersensitivity reactions is something else to be considered about, but these are very, very rare. Now, what I'd be concerned about is oftentimes we're dealing with young asthmatics, and if they're young women, they could potentially get pregnant. Omalizumab has been the one that's been around for the longest time now. There's been a prospective observational study, so you wouldn't do this on purpose, but someone who got pregnant not on purpose, and they had at least one dose of omalizumab, have been put into a registry called the EXPECT, and these study results are coming up soon. So far, the initial indications are that there seems to be no particular harms to the pregnancy, but I'd like to see these exact results. So far, we can't see these are safe in pregnancy, but we haven't seen any harm from them yet either. The anti-IL-5 therapies, again, there's been no study in pregnant women, and again, these things are all being looked at a post-marketing situation, and a registry is being made there. If you happen to be pregnant and have been given a biologic, there's the name of the registry, mothertobaby.org/asthma, if you're interested. So for the clinicians in the audience, what can you do? And as a patient, what would you expect to do with your clinician? Go back to the basics: inhaler technique, inhaler adherence, comorbidities, trigger advice, to firm up your diagnosis. First thing you can do is just add on tiotropium or Spiriva or some other LAMA. The only one that has evidence for it right now is tiotropium. I think if the IgE is elevated, Xolair would probably be omalizumab would be the first choice. If the IgE is not elevated, then if you have exacerbations, an anti-IL-5. We have an anti-IL-4/13, which is also indicated for atopic dermatitis. But I can also tell you that I've seen anti-IL-5s significantly help dermatitis and rhinitis as well. So a lot of it's going to be based on the eosinophil count and their history. As I mentioned, there are people who have neutrophilic asthma, and then you have to reach for different things like azithromycin. Roflumilast is something I'll just mention to clinicians. Some of you have experience with this drug for for COPD. It's not indicated for asthma, but actually it does have asthma activity as well. And if you're really stuck for someone who can't afford a biologic, consider that drug and feel free to contact me about it. And again, bronchial thermoplasty may be something you consider for people with muscle issues mostly. So in primary care, and I'll speak to the clinicians and the patients, as for the clinicians in the audience, let's find people who can benefit from our biologics and stepping up therapy. Don't just accept prednisone prescriptions day to day. It's not okay. Take care of the basics, which we talked repeatedly here about. Consider doing some phenotyping and add on some tiotropium while you're referring to someone to consider a biologic. You can refer to a respirologist, to an allergist, to someone with an expertise in asthma and an interest in asthma. Even if your patient has gone on to a specialist, continue supporting your patient, continue working on things, go back to the basics with them. Make sure that you stay involved, because obviously it's going to be easier for them to see you as a primary care doctor than the specialist. If they are on oral steroids, please recognize this has harms. Recognize they have harms to the bones. You may want to consider a bisphosphonate for prevention. Make sure you get the eyes checked to make sure there's no glaucoma or cataracts developing. And of course, consider the risk of pneumonia. The NACI guidelines suggest that everybody who's on long-term inhaled steroids should get a Pneumovax shot or pneumonia 23 shot, the old pneumonia shot. And that's not something that everyone's doing. There's a new pneumonia shot called Prevnar, which is the conjugated pneumonia shot, which probably works better, and certainly the two of them together is the best combination. Give the Prevnar first, then the Pneumovax second. So consider whether or not they've had pneumonia shots if they were on regular inhaled steroids, because your risk of having pneumonia is higher if you're on regular inhaled steroids. As a patient, what should you do? Well, again, basics. Make sure please take your medication regularly. Have you had a diagnostic test to diagnose your asthma? Are you just increasing your medication more and more and not getting anywhere, but never actually had a firm diagnosis? And I understand why that happens. There's barriers to getting diagnostic tests occasionally in Canada, but you as a patient don't accept that. You want more. Make sure you're taking your medication regularly. Make sure you're taking your medication properly. Have it observed by your pharmacist. Have it observed by someone you know, your asthma educator or your clinician or everybody. Check the YouTube things. See your doctor. I mean, in these days now, it's a little hard to see your doctor. I've been working on how to do virtual visits for different respiratory conditions. So your clinician, feel free to look at the fpagc.com website where I'm housing these things. If you've got concerns, speak to your doctor about it. What are you concerned about? What are you afraid about? Are you afraid about side effects? Have the conversation. We can reassure you that these medications are safe. And if they're not safe, which is the lesser of two evils? And we can discuss those things and work on it with you. Vaccinate for influenza, pneumococcal vaccine. Remember that you want to make sure you don't get whooping cough, so make sure your Adacel and your pertussis vaccines are up to date, and you might want to consider a shingles vaccine if you're a little bit older. Recognize that I know that this makes us anxious, and it may be a factor. And I wanted to close off with some issues that we don't normally talk about, which is how to improve our breathing because of the issue of dysfunctional breathing. So we talked about medication and all the pharmacologic effect. I wanted to talk about some non-pharmacologic stuff for just a few minutes. I'll go through this quickly. So what happens here with people who get short of breath, and I completely understand that, it's going to make you anxious. And of course, if you're anxious, you breathe faster. If you breathe faster, you get more short of breath, and all of that is quite fatiguing. And this becomes a cycle, and of course, can deteriorate all by itself. And some of you have recognized this has happened to you. So this anxiety breath cycle needs to be broken. So the first thing you have to recognize is there. What is happening? What are you afraid of? What can you do about it? How are you going to plan to improve things when you feel poorly? How are you going to make sure you can still do the things you want to do? Don't overwhelm yourself with issues. Deal with one thing at a time. Nobody can solve 100 things at the same time. You have to break this down to one thing at a time. And I give this example to people all the time in the office when I say, there's 30 people in the waiting room. Everyone's upset with me and they're waiting. I'm not happy about it either. I can either get upset and overwrought and then not get anything done, or I can deal with one person at a time and get their issues dealt with as best as I can, as quickly as I can, and move on to the next one so that everyone is dealt with. That's how we have to look at life. Deal with issues one at a time, prioritize them, and deal with them. And stay positive. We're going to be able to work these things out. We've got through a pandemic. We're going to be able to get through this as well. Now, dysfunctional breathing is very common. This is an article written by a friend of mine, Michael Thomas, that talked about in his study of 7,000 patients, about a third of women and a fifth of men had scores on these different questionnaires called Nijmegen questionnaire that showed dysfunctional breathing. So it's a very common thing. Now, I want to give you some ideas of things you can do for your breathing to make you feel better. So some of these are going to sound a little hokey, and some of these you probably tried, but these all have been shown to make some differences. And I've got these out of a pulmonary rehabilitation program from the UK. So pursed lip breathing is one of the first thing. And the idea here is that you're inhaling slowly through your nose until you feel full, and then you purse your lips like you're about to whistle, and you exhale, keeping your lips pursed. And you breathe out longer than it would take you to breathe in. So you breathe out nice and slowly. Don't force yourself too much to empty because it makes you feel uncomfortable. Just do that breathing in and out. And it's sort of a positive pressure ventilation that allows you to ventilate your lungs a little bit better. So breathing in through your nose slowly and breathing out quickly. I know. Breathing retraining is like this. You sort of lay down, get comfortable, you close your mouth, and get breathing through your nose is very important. It makes a big difference to this if you breathe through your nose right. That's going to be my next slide as well. Relax your shoulders and your chest. Put one hand on your stomach, one hand on your chest, and breathe in and out normally, just normal breaths. Then try to keep your chest still and just let your stomach rise. So trying to use using your stomach. So normally we encourage our diaphragm in breathing, but you want to be able to capture your stomach muscles and allow your diaphragm to fall a bit better, rather than just using your chest. Just allowing your stomach to rise in and out. So again, breathing in through your nose, out through your mouth, allowing your stomach to rise and fall gently, again, not forcing it. I've talked about breathing through the nose. Another brief retraining, and this one's actually uncomfortable. And what I think it does is it trains your brain to be comfortable with being a little bit short of breath. So again, sitting up, breathing in and out through your nose, relax everything, take a nice normal breath, and breathe all the way out. Again, using your stomach breathing. Now, you've done all this already. Then, at the end of your breath, pinch your nose and hold your breath. And at a certain point, you're going to start to feel a little short of breath with an urge to breathe. And then you let go and you breathe. What you're doing is you're teaching your body that being a little bit short of breath is not a bad thing. And you can sort of progress at this for a little while. Don't do it till you're too uncomfortable, but just teach your body that I'm a little short of breath, I'm okay. It sort of calms the brain down and teaches you that you can actually cope with this a little bit better. So do this, a lot. Do it a couple times a day. Try to build up sessions about 15 minutes a day. Practice the 3 to 4 controlled breath holds a couple times a day, and try to breath hold all the time, to nose breathe all the time. And if you want to look this up online, University of Southampton Asthma UK can tell you about this. This has all been looked at by a Russian professor who died in 2003 called Buteyko. He talked about Buteyko breathing. He believed that part of the reason people get anxious, they breathe too fast and they breathe down their carbon dioxide levels, and that this hypocapnia drives some of the pathophysiology of asthma. I actually don't believe it actually changes asthma, but it certainly improves the symptoms. And here's a study that's actually looked at this that shows, and some of you will have heard about people saying, oh, Buteyko breathing cured my asthma. It's not going to cure your asthma. It's not going to treat inflammation, but it does actually improve symptoms because it teaches you to learn to have less symptoms and does decrease bronchodilator use, but does not improve lung function. So this is something you can do in addition to your pharmacotherapy, not in place of it. That's very important. I'll close up by reminding you that the Asthma Canada has lovely resources called Managing the Impact of Severe Asthma. Please have a look at this. You can download it or get it sent to you. And it's full of really good resources to help you deal with your severe asthma. I hope I've given you some ideas of how to cope with your severe asthma, what questions to ask, both as clinicians and as patients and as family members. And I look forward to hearing any comments from you. And thank you so much for your persistence in coming back and watching this webinar. All the best.
And that's a great point, Dr. Kaplan. Thank you so much. And again, these and many other resources are available on our website, asthma.ca/publications. You can get these resources and many others to help you not only get more informed about your asthma, but to maybe help someone in your circle or your network or your family manage their asthma and live their lives symptom-free and healthy. And we want to thank Dr. Kaplan again so very much for this great presentation and for sharing such important information with us. We appreciate your guidance and support very much, not only on this webinar, but as part of Asthma Canada's Scientific and Medical Advisory Committee. And thank all of you for tuning into this webinar to learn more about your choice when it comes to the use of oral corticosteroids, or OCS, in managing your asthma or one of your loved ones. Speaking of support, We here at Asthma Canada, as a charity, we can only do the work that we do through the generosity of people like you. If you found this webinar useful, please consider making a donation at asthma.ca/donate. On this page, you can find more about information on how to support Asthma Canada community and all the vital programs and services we offer. And that concludes our severe asthma webinar regarding your choice when it comes to oral corticosteroids, or OCS. If you want to know more about what Asthma Canada does, again, head over to asthma.ca and look at all of our information about our programs and services and how you can support our mission. Also, sign up for our Asthma Canada Member Alliance, or our ACMA, for the latest education, advocacy, and research updates from us, and how you can get involved in helping support millions of Canadians with asthma and their caregivers. Again, thank you so much for tuning in. We'll have another webinar in the near future. Until then, stay safe, and thank you.